Welcome to The View on GU, the place to be for translating uro-oncology knowledge to action. Here are your hosts, Drs. Ali Khan Lalani and Christopher Wallis.
Hello and welcome to The View on GU. Thank you so much for listening and watching, ladies and gentlemen. I'm Ali Khan Lalani. I'm joined by my co-host, Christopher Wallis. Chris, you're back fresh off of vacation. How are you feeling, man?
I'm good. It's always nice to step away, get a little break, spend some time with the family. You know, it's as a redhead, there's a fine line in Mexico between going from ghost to lobster. So we try and thread that needle as best we can.
You're looking good, man. You're looking good. You're looking like you got a nice tan. I love it. I love it. That's all good. And as we record this, it's been great weather this week. I think it's going to be a great summer. So we're really looking forward to that. In terms of what we're going to cover today, I think it's a topic we've been wanting to talk about for some time. You know, this whole context of biochemical recurrence in prostate cancer. Where are we at now and where do we see the field going? A bit of a rundown. We'll cover the natural history of prostate cancer getting to this scenario, what options there are currently, and what treatments we see on the horizon, really as we work through a very multi-D context. So, Chris, why don't you kind of set the stage for us and take us through this scenario of biochemical recurrence and how we get to this perspective from a patient's sense of things in a localized setting?
Absolutely. So, biochemical recurrence is one of these intermediate sort of passing through disease states is the way I think about it. In some cases, it actually offers us a second chance at cure. And I think that's the most interesting part of it from someone who treats prostate cancer locally. So when we, take a little step back, patients who have localized disease are offered, either surveillance or surgery or radiation based on their disease characteristics. And regardless of what they're choosing initially, we're always monitoring these patients after their initial treatment approach to make sure that they don't have the disease recur. So for patients who have either surgery or radiation, we're typically doing PSA checks every 3 to 6 months initially, and then slowly spacing those out. And when we're monitoring people, we're looking for that PSA to start rising over time. So, we have different definitions, whether you had surgery or radiation, typically a 0.2 threshold for the PSA is used after surgery, and the Phoenix is a rise by greater than 2 above nadir for those radiation patients. And while this is, hopefully a situation we're avoiding as best we can, we know based on disease characteristics, this is somewhere between 20 to 40% of all men who are having local therapy are eventually going to have biochemical recurrence, at least based on historical studies. I think we hope that we're doing better today than we were in the past, but that's sort of our benchmark. And then there's a lot of great data that comes out of Johns Hopkins that trying to helps us to stratify these men and figure out who's really at risk of disease progression and who's going to have a more indolent course. So we can certainly chat about that.
Yeah. So let's assume the patient has had the standard of care, whatever it may be for definitive local, and the patient enters this BCR, biochemical recurrence setting. To me, the options would be potentially observation, some form of salvage local therapy. We have novel imaging to really dig deeper and look for further areas of disease to treat, and then perhaps systemic therapy. So in your mind, let's kind of go through the observation, salvage local, and then the imaging aspects. Maybe take us through who are the best men in your view for each of those.
Yeah, so I think, we have a fortunate situation where we had urologists back in the day who didn't really believe in anything. And so Pat Walsh, in his radical prostatectomy series, didn't believe in any intervention until clinical evidence of metastatic disease. And so we really get to see the natural history of this play out. And that means that we can, dwell on his experience. And there's sort of really seminal papers that were written by Pound and written by Steve Friedland. And they really helped define important characteristics for substratifying this patient population. And so there's 3 big ones that I think about. The first is the time from surgery, in this case, or radiation therapy, I think is also fair, until recurrence. And so the longer it takes for the recurrence, the more indolent the behavior. The faster it comes, the more aggressive, the more we need to worry about. So that's one. The second is the Gleason score at the time of surgery for radical prostatectomy patients, or the biopsy Gleason score for the radiation patients. So obviously, higher grade histology is a more aggressive phenotype. And then the last important one is the PSA doubling time. So the faster that PSA is rising, the more we worry about disease progression and disseminated disease. And so there's stratification across this as a continuous variable, but lots of people end up, dichotomizing it around a cutoff around 9 months as a doubling time. And so that helps us define a subset of higher risk and lower risk patients. And so when you're going to use that information when you consider your options. And so observation is obviously an approach that trades off some cancer control for decreased morbidity. And the notion here is probably that men with less aggressive or lower risk BCR characteristics who have greater competing health risks, so older men, more comorbidities, may be better served with this sort of less intense approach. So that's, in general, what I'm thinking for an observation cohort. Salvage local therapy, I think, really heavily leans on what your primary therapy was. In someone who's had a radical prostatectomy, the standard of care here is salvage radiation, and we want to hit them relatively early on. So PSAs around 0.2. We know that when you wait longer, if you let the PSA ride up, your chance of cure is lower. But in the surgical patients, when they get appropriate salvage radiation, this is really a chance for cure and a second opportunity to cure these patients and keep them off lifelong therapies, which I think is a real great option. For the radiation patients, we have, I would say slightly fewer options here. In a certain subset, salvage ablations are certainly feasible. So there's people across our country doing, salvage cryotherapy, which I think is reasonable. You have to be pretty sure that you've got only localized disease. So you need, in my opinion, you need repeat biopsies to prove that you've got disease there. You need good imaging to exclude just in disease outside the prostate. But it's, again, a potential second chance of cure. We do salvage prostatectomies rarely, I would say, around here.
So before we get into systemic therapy, let's talk about briefly PSMA PET. Who should get it? We're seeing some data about the appropriate cutoff and some PSAs that clearly we can expect metastatic disease, some PSAs that are way too soon, I think, to expect metastatic disease. What would you suggest? And are we overdoing it, underdoing it? Is the field just right?
Yeah. So, a lot of this is so jurisdiction dependent, right? And availability and access is a big, big question. So there's the question which you're asking, which is like, when should we do it? And then there's the related question, which is, when can we do it? They play together some of the time. So those of you who are in Ontario will know the PrEP registry criteria. And essentially, in any biochemical failure space, the PSA threshold that they have delineated is 0.1, which is honestly pretty early. It's a relatively low threshold. It gives us a pretty wide license to use PSMA PET in these patients. And I think it's not unreasonable, but the important thing, I think, is to remember that when PSMA PETs are negative, that doesn't mean there's no disease. The PSA is there. And if anything, that kicks us back. And that's the patient who best benefits probably from those local salvage therapies. So in the surgical patients, if you have a BCR, you've ordered a PSMA PET early and there's nothing there, that's the perfect patient for salvage radiation therapy, because you really have a chance at cure, because there's such a low volume of disease that even on PSMA PET, we're not seeing evidence of disease. And so that's certainly how I interpret it in that setting. As the PSA rises, obviously your chance of a positive test is going to rise, but you also probably are decreasing your probability for cure. So I would not, in my practice, wait for PSAs to rise just to find something on PSMA PET, because I think you're missing that opportunity. And the sweet spot for the salvage radiation is with that low PSA around 0.2. And so, that's how I use it in my surgical population.
Right.
Or when things are discordant. I had a patient recently who had adverse characteristics at the time of prostatectomy, but negative margins, negative nodes, and yet a persistent PSA. And so I went looking with the PSMA PET, and he had weird out-of-field nodal disease. And so you can use it as that sort of problem-solving tool also when the picture doesn't quite make sense.
Fair enough. And so as reason I ask is because depending on what we find, there becomes a question about systemic therapy. And I think our viewers and listeners know that the MCRPC setting is where a lot of systemic therapies are first studied, and we have a bevy of options. We've seen ARATs and combination with chemotherapy used now standard of care in MCSPC setting. We have ARATs in the NMCRPC and more to come, right, in the localized and earlier setting. So let's just tee this up and maybe dovetail into the Embark trial. And just very briefly to set it up for folks, this was a 3-arm randomized, more than 1,000-person trial that had a specific patient population included. So these largely were patients who would have had a PSA of 1 or greater after a radical prostatectomy, and at least 2 above the nadir for those who got primary radiation. They needed a doubling time up to 9 months inclusive, no metastatic disease on conventional imaging, and having an appropriate testosterone level. These patients were stratified by a screening PSA, their doubling time, and some prior hormonal therapy. And the 3 arms in this trial was looking at enzalutamide with leuprolide versus placebo versus leuprolide, and then an interesting arm of enzalutamide monotherapy. And importantly, for patients who achieved PSA less than 0.2 at week 36, these patients who have that could suspend treatment at week 37 and monitor PSA and then reinitiate if PSA rises. And if they didn't, they would remain on treatment. Now, in terms of primary endpoints, MFS or metastasis-free survival for the combination versus leuprolide was the primary endpoint. And then other important secondary endpoints were also studied. And really, Chris, before we get your take here, just to remind everyone in terms of who actually was in this trial based on what those inclusion criteria were, we saw a median PSA doubling time in this group somewhere in the 4.5 to 5 range between the arms. We had, importantly, patients having a median serum PSA in the 5 to 5.5 range. And then importantly, I think when you look at primary definitive therapy that these patients had, half of these patients had surgery followed by radiation therapy. Another quarter had radiation therapy alone. Again, both of those would seem very fair game. And then there were a quarter of patients who had just prostatectomy alone. And interestingly, patients could have been excluded from the trial if after RP, patients would have been considered by the investigator to be a candidate for salvage radiation. So there was some reason why these patients had just prostatectomy alone. Again, a quarter of the population. So, Chris, why don't you take us through some of these efficacy outcomes and what really we learned?
Absolutely. So I think you've set it up really nicely, and we have sort of 2 pairwise comparisons. The way the authors set up the sort of statistical design of this study. So we have the Enza plus ADT versus ADT, and then we have Enza mono versus ADT. We don't have an Enza ADT versus Enza mono comparison here, although everyone's going to naturally do that just by the eyeball test. And I think the important takeaway for what most of us will consider the sort of standard way to give Enza, which is with ADT, is that we see really important improvements in metastasis-free survival. And so at 3 years, we see about an 8.5-9% improvement from 83.5% in the ADT only arm to 93% in the Enza ADT arm, and at 5 years that curve splits even further, and so we have at that point over a 15% improvement from 71.5 to 87%. And so overall, you put that in the context of a hazard ratio, and we're talking about nearly a 60% risk reduction for metastasis or death as an endpoint. So metastasis-free survival improved by 58%. We see this interestingly across nearly all subgroups. And so the authors looked at things like PSA doubling time, baseline age, baseline PSA, use of ADT in the local space, prior surgery. All of these subgroups benefited essentially equivalently, which is interesting. In this combo arm, we see a little early data, I would say, in the overall survival space. So we're seeing curves start to separate a little bit, probably around the 5-year point. They're starting to diverge a tiny bit, but we have a hazard ratio of 0.59, which seems really impressive, but our event rate here is pretty low. So I think we're going to need to learn more about that, but certainly that's the goal. And we did see in the NMCRPC space a similar progression where we saw MFS benefits early translate into OS benefits later. And so, we can be hopeful that that may apply into this patient population as well. We can then jump to the enza mono arm. The data is actually fairly similar. I would say a little bit less compelling. The curves don't separate to the same degree. The hazard ratio here for MFS is 0.63, so it's attenuated, still showing some benefit to the enza mono arm. But in that context, before we hop to toxicity, I'm interested in your take as a medical oncologist. What do you think about the idea of using enzalutamide as monotherapy? Certainly, we used bicalutamide as monotherapy historically before you and I started to practice. What do you think about doing this going forward?
I think this is an interesting part of the study because it's, I think, a small piece of a larger question patients ask. Like, quite frankly, the field is trying to ask which patients need how much, and is there a component of what we call maybe de-escalation or kind of bespoking which treatments patients can get from either genomic testing. But I think here, having a monotherapy agent, especially given this context and how well they may do for some time, is important. Frankly, patients ask about this pending their response in an MCS-PC setting. Is there the possibility of trimming one of the ADT or the ARAD? And I think in this situation, having more data come out from multiple trials about using ARAD alone, I think will help us understand, is this safe? Is this reasonable? And what are the toxicities for these patients? So I take this as another piece of the pie when we try and answer this exact question: who can get away with ARAD monotherapy alone? Again, in the appropriate context. And I think let's quickly go into that other piece that I mentioned: is some of those patients that could have stopped based on their response and had so-called intermittent treatment. What about this intermittent concept, and what do we learn about that patient population?
Totally. So the Embark investigators don't do intermittent therapy here quite the same way that we would think about it in intermittent ADT. So that's obviously harkening back to Juanita Crook's PR7 trial. And in that trial, I think a lot of us practice this way: is you start ADT, you maybe give like a 9-month lead in, and then as long as the PSA and testosterone respond appropriately, you hold therapy. When it rises, you reinitiate, and you cycle this on and off and on and off. The Embark investigators didn't do that. They did it one time. So at 9 months, if you had an appropriate response, you got a drug holiday. And depending on which arm you're on, the duration of that drug holiday was not insignificant. Like some people were off therapy over a year. But when you reinitiated therapy for a rise in PSA, they then went on to lifelong therapy. So this is a little bit different than the way I think our community thinks about intermittent ADT, but it is another way to think about, decreasing the burden of therapy for our patients and trying to thread that line between, optimizing oncologic outcomes while also preserving quality of life as best we can. And so I think it's a good opening salvo, and I think the community will try and sort of evolve and integrate this approach with what we know from PR7 and intermittent ADT, because I think the considerations are different in these patients who don't have radiographic disease than those who do. And so coming off therapy maybe has a more compelling argument here.
And so what are the costs to patients? I mean, toxicity in this scenario, we often look at all grades, and we sometimes in metastatic settings focus on what's grade 3. But as you said, these are patients that have different contexts. Even some of these low-grade toxicities may be very quality of life affecting. So what was the kind of cost of doing business for the patient?
Absolutely. And I think the fortunate thing we'll see here is that grade 3 or greater toxicity is actually really uncommon. And I think that's reassuring, but also something that we should expect. I think giving patients grade 3 toxicity to treat a lab number when they don't have any symptoms or no radiographic evidence of disease would be a hard argument to sell.
Exactly.
And so it is reassuring, but it's also, I think, what we should expect. I think overall, the toxicity profile here is what we would think it should be. You get the ADT-driven toxicity is the most common things: hot flashes, fatigue. Importantly, though, we were just talking about the enza mono arm. As you would expect, with a very potent anti-androgen, and you're not suppressing the whole axis, you get pretty significant gynecomastia. So nearly half the cohort had some degree of gynecomastia if they are on enzalutamide monotherapy, 45%. And so that's, a really important consideration when we're trying to think about the role of enza monotherapy. Certainly it's going to be libido preserving because if anything, is actually going to raise testosterone rather than lower them. But that comes at the cost of that gynecomastia with the peripheral conversion to estrogens. And so, we see the other enza side effects as well, things like hypertension, falls, fractures. They show up, but I think at rates that we can manage and things we can probably tolerate even in this earlier patient population.
So, I think this is a great summary of the Embark data. Obviously, there's other approaches, as you said, right? The field moves quickly, and let's even step away from the PSMA piece, which could change all of this. But there are other things. I'm curious about your take on Presto, and just to remind some of our viewers and listeners, this was again a 3-arm trial, randomized equally for patients who had prior radical prostatectomy, biochemical recurrence with PSA over over 0.5, a doubling time of up to 9 months. Again, conventional imaging showing no metastasis. And it allowed for some prior adjuvant or salvage radiation, unless not a candidate for radiation therapy, and randomized to an LHRH analog. Another arm was the analog plus apalutamide, and then the final arm was analog plus apalutamide plus abi-pred. So, Chris, what do you take away from that, from the kind of Presto data?
Absolutely. So it was interesting. Presto was presented at the same AUA 2023 meeting that Embark came out, and we just saw the paper in JCO, I think maybe 2-3 weeks ago now. So I think there's a couple of things here. Number one is that this is a phase 2 study, right? This is a bit earlier. So we're not looking at the same MFS endpoints. We're looking at a PSA-driven endpoint, which changes maybe the way we interpret it a little bit. But we see, similar magnitude of benefit between the two active arms compared to the ADT alone. And so I think when we put that in context with what we know from Stampede in the high-risk localized space, we really don't need to do double ARSI. So we don't need the ABI added to your androgen receptor targeting agent, whether it's ENZA or APA, depending on the study. So, I think that's one key takeaway is if you want to intensify, that's great, but you probably don't need to use 2 drugs. You can get away with 1. And I think, this fits in the greater context of what we know about ARSIs, which is that for the most part, where one is efficacious, the others are probably as well. I think we have, a little bit less robust data here from Presto than we did from Embark, but we see, I think, a similar magnitude of benefit, right? We have hazard ratios of 0.59, 0.53. And so I think this is an approach that is, logically feasible. I think we don't need the double arm, but, phase 2 data like this is not going to get us access, unfortunately, in clinic.
Yeah, no, absolutely. And it's another way of looking at this. So if we summarize this kind of space, look, this is an intermediate state, I guess, between localized and metastatic disease. I think you've shown nicely that PSA doubling time can be prognostic. I think it's a heterogeneous setting. We have lightly touched on the PSMA PET imaging. We could do a whole other podcast on that. So kind of the state of the union. And let's assume, Chris, that our viewers and listeners are in jurisdictions that might have access, whether it's already approved or through access programs that I think patients would want to have. So let's assume these options are out there. What would be your state of the union of BCR as of today, or at least the short-term horizon scan?
Absolutely. So I think, to contextualize this, we only have to go back 1 or 2 years, and we have an AUA guideline that says we don't treat anybody in this space, right? You just monitor. You do PSMA PET imaging if you can. You can consider a clinical trial if it's out there, but we don't give ADT. And that's an important context because the clinical trials we've just discussed, the baseline control arm is ADT monotherapy. And that wasn't actually part of our guidelines when these trials came out. But what we've seen from these trials is that the event rates are not insignificant, and progression to metastasis happens relatively quickly for these patients. And so, I think the reality is that many, if not most of these patients in our practices are going to be getting PSMA PETs. And I think what this data does is it supports the notion of giving intensified systemic therapy while we also consider the metastasis-directed therapy. And so I think the field is already sort of progressing in that direction. The original metastasis-directed therapy studies were all about trying to delay the start of ADT. So you think back to like Pete Ost's STOMP trial, was all about ADT-free survival as an endpoint. But I think this data adds to the sort of philosophy of adding that intensified systemic therapy. My belief is probably that if you look at the Embark population, at least 80 or 90% of them would be PSMA positive. You'd have localizable disease on a scan. And so, I think when we look at our current way of practicing, these patients are going to be getting PSMA scans in high numbers. And this just reinforces, I think, the importance of having that intensified systemic backbone for those patients who have the high-risk characteristics. So the PSA doubling time, the high absolute PSA value, certainly the short time to recurrence, those features all, I think, really support the notion that we need to give a strong systemic backbone, and then we can also maybe add local therapy for their metastatic sites.
Yeah,
I guess the question then, sorry, for you is how do we do that? So, how many cooks need to be in the kitchen, and how do we share the care here?
I mean, I would agree. If we just had a BCR state that was a new add to our clinic, let's say we weren't ending up finding metastatic disease on PSMA PETs, just we added a new state to our scenario, I think it's a fair game for a variety of stakeholders, right? The medical oncologists, rad oncs, and urologists to come together at any jurisdiction, community, whatever it may be, to say, how do we share this care? I think it's important that you actually have this a priori before these referrals come in, because I have seen, and we've both heard, we've talked about this off camera, that there are jurisdictions where there's serious conversations about perhaps medical oncologists feeling we can't simply absorb a new BCR state. And frankly, this is part of a localized setting. All three stakeholders, right? All three multi-D players here are physicians who are within scope to try and deal with patients in this localized setting. So it would be fair game to ask the ARAD, if it's so included, to be part of the scope of care of the physician who is providing the local treatment. So the automatic that every ARAD in any scenario for any patient needs to see a medical oncologist might be very jurisdictional dependent, where in some places there may be physicians in a localized setting who maybe don't use ARADs as much, and it's been agreed upon that all these patients would get referred. This denominator might not be a massively new add for that specific community. But I think, if we just isolated and said we're adding all these patients now to medical oncology clinics, I think it's about timeliness of care. And frankly, people who have had good experiences with ARAD in a localized setting. Now, it's not to be controversial and to exclude medical oncologists. That's not my intent. But, I think we have to have that honest conversation. And there are other places that have said, listen, any systemic therapy would be referred to a medical oncologist. And I think we have to have a real conversation about how feasible is this. Because it's not just giving it, as you showed, right? A one-time prescription and off you go. I mean, these are patients that are going to do well. They're going to be on therapy. They're going to be adding to the long-term care in our clinics. So, I think, frankly, it's going to need a jurisdictional discussion. We, at our site, I think, are fortunate. We have surgeons and radiation oncologists who feel that, hey, the localized setting has evolved, and therefore my involvement will evolve as well. And I think that's a very fair ask. But I'd almost ask you, Chris, because I think what you're saying is that let's assume PSMA PET becomes in the water for a lot of our listeners and viewers in many jurisdictions around the world, accessible outside of registry, some, in some places reimbursed and covered. We are going to be finding disease that might need so-called MCSPC type treatment. It might need radiation in some areas. It might need both. And so this makes our own tumor boards very innovative. We need and we benefit from having very good second reviews of PSMA PET scans. How are you navigating this now? Or how would you suggest we navigate this from a uro-onc point of view to make it most seamless for you? Because you could have a lot of these patients, and to provide the patient kind of effectively timely care. Like how would you map that out from your end?
Yeah. So, I think it's going to vary based on the physician. It's going to vary based on the patient. For me, I'm pretty happy coordinating care and I like doing that. And so, for example, I have a patient who is, uh, has a biochemical recurrence event. Depending on the parameters and how the situation looks, sometimes I'll refer straight to a radiation oncologist for some salvage radiation therapy. If the picture looks a little bit muddied, I might arrange a PSMA PET to get a bit more information before I initiate that referral. Or sometimes those two things happen in sequence or simultaneously. And so that I think is reasonable. Once they're in the radiation oncology clinic, we often do shared care where they come back and see me in alternating visits with the radiation oncologist. And then, for a surgically treated patient, ideally, they're not getting into the Embark style indication until after they've had their radiation therapy. So then it's a question of, between the radiation oncologist and myself, are we comfortable prescribing an ARSI? Where I practice, I think most of us are. I think for the most part, we probably involve medical oncologists at this point only when things are atypical.
Mm-hmm.
But there's lots of jurisdictions I know where, the localized treaters, the urologists and radiation oncologists aren't happy making those prescriptions, and it's not necessarily just the prescribing; it's the toxicity monitoring and dose adjustments when they're needed, and all that other aspect that comes with writing an ARSI script. And so, I think we don't want to push people outside their comfort zone, but we want to encourage them to maybe expand what their comfort zone looks like. Because as you alluded to, right, in this cohort, at 5 and 6 years, we still have 80+% of the cohort alive, which means that this is a patient population that's going to live for a long time. It's pretty atypical, I would say, in the average med-onc clinic, and looks more like an average urology or radiation oncology clinic. And so it maybe makes sense to keep them in that environment when we can.
Yeah, and I think as long as those touch points are made at critical points, right? Hey, can we leverage radiation here? Should we approach this as an MCSPC scenario? What are we really doing? I think that having those conversations will allow the patient to get the care and then the right clinic to look after them. And as you say, people's comfort if they can expand, because look, we conducted these trials in localized settings for a reason. A lot of investigators who were on there are multi-D. It's not that it's only medical oncologists running these trials or delivering them at their centers. So when it becomes approved and in the water, I think it's fair to ask that the major players in the localized setting, which for patients, they have lovely relationships with their urologist or their radiation oncologist who gave them primary therapy. So I think an ARAT is fairly safe to be considered by a variety of prescribers. I think as this field evolves and we maybe add other genomically directed therapies, watch this space. In 5 years, we could be adding other agents as well. I think we'll still need to evolve. So we will have to have some jurisdictional understanding of how does this denominator grow in our clinics. But I think for now, it does need folks to say this is within scope. The field has evolved and I feel comfortable. And obviously those who don't, we need to be ready to take that on. But yeah, this is cool. Prostate cancer is evolving kind of every conference or every year. And it's exactly what makes these kind of conversations, I think, important to have. So I love chatting with you on this today, man. Chris, and welcome back. It was nice to connect. And I know we're going to see each other shortly in person off camera. That'll be even more fun too.
Absolutely. This has been a great conversation, I think, and really hopefully a kickstart to some local conversations that people will have about how to best care for these patients. And I want to thank everyone for tuning in today, listening. Hopefully this has been interesting, a little thought-provoking. If it has, please subscribe, give us some feedback and some comments. And we'll look forward to seeing you on the next episode of The View on GU. For my co-host, Ali Khan Lalani, I'm Chris Wallis. Thanks again for joining us.